Hello, anesthesiologists. Thank you for your hard work today in administering difficult liver transplant anesthesia. Today, based on the latest guidelines from international academic journals published between 2024 and 2026, I will review the latest updates on cardiovascular evaluation prior to liver transplant surgery. Namaskar, anesthesiologists. लिवर प्रत्यारोपण के कठिन ऑपरेशन में एनेस्थीसिया देने में आज आपके अथक परिश्रम के लिए धन्यवाद। आज 2024 और 2026 के बीच प्रकाशित अंतर्राष्ट्रीय अकादमिक पत्रिकाओं के नवीनतम दिशानिर्देशों के आधार पर मैं लिवर प्रत्यारोपण सर्जरी से पहले हृदय संबंधी मूल्यांकन पर नवीनतम अपडेट की समीक्षा करूंगा। Right, let's get straight into it, shall we? I know so many of you have literally just stepped out of theater after managing some incredibly complex hemodynamics in end-stage liver disease patients. Today, we are going to completely unpack a cardiovascular complication that can absolutely make or break a transplant. I'm talking about portopulmonary hypertension, or POF. The entire landscape of how we define, screen, and manage this condition has shifted massively recently, especially with the 2026 International Liver Transplantation Society guidelines, the 2022 ESCRS updates, and the incredibly comprehensive 2023 CHEST reviews. We are going to break down these dense, high-yield updates today, translating the theory into the practical steps you can take straight back to your transplant centers.
Here is our clinical pathway roadmap for today's session. Number 1, patho and updated definitions. Number 2, screening and hemodynamic diagnosis. Number 3, PAH-targeted medical therapy. Number 4, candidacy and risk stratification. Number 5, perioperative and post-LT management. And finally, number 6, the 2026 ILTS guideline updates. Let's jump right in.
Section 1, patho and updated definitions.
So, let's start with the foundational science of portopulmonary hypertension and its clinical burden. Now, why do we care so much about these precise definitions and mechanisms? Because in our highly specialized transplant world, the line between an acceptable surgical candidate and an absolutely contraindicated one is drawn by these exact hemodynamic numbers. It is quite literally a matter of weightless survival. Think about the clinical features we usually see. The symptoms are notoriously tricky, aren't they? You've got exertional dyspnea, fatigue, things that are incredibly nonspecific and so easily masked by the patient's underlying end-stage liver disease, the deconditioning, and the massive ascites. But here's a clinical pearl. If you're assessing a patient and you notice lower extremity edema that just feels completely disproportionate to their level of ascites, that should immediately trigger your clinical suspicion for right heart strain. But let's look at the risk factors, because this is where the pathophysiology gets genuinely fascinating. If you look at patients with chronic liver disease, being female and having a history of autoimmune hepatitis significantly ramps up the risk of developing POFAP. We also know that the presence of large spontaneous protosystemic shunts heavily correlates with moderate to severe POFAP and, worryingly, a diminished response to our medical therapies. Conversely, and somewhat counterintuitively, hepatitis C viral infection actually appears to be associated with a decreased risk. We are finally beginning to unlock the molecular black box of this disease. It's not just a mechanical issue of portal pressures backing up. We are looking at complex disruptions in estrogen metabolism, macrophage migration inhibitory factor, and crucially, mutations and dysregulation in bone morphogenetic protein 9 and 10 signaling. Normally, a healthy liver produces vascular quiescence factors. When the liver fails, or when blood completely bypasses it through large shunts, the delicate pulmonary endothelium is suddenly exposed to this absolute barrage of unmetabolized vasoactive mediators. This constant exposure is what drives that profound pathological pulmonary vascular remodeling.
And understanding that remodeling brings us to a monumental shift in our diagnostic criteria. We all rely on right heart catheterization as the absolute gold standard, but the goalposts have moved, and you really need to be aware of this for your clinical practice. Based on the harmonized consensus from the 6th World Symposium, the 2022 ESC/ERS guidelines, and now fully formally adopted by the 2026 ILTS guidelines, the hemodynamic thresholds have been lowered. Previously, we were looking for a mean pulmonary arterial pressure, or MPAP, strictly greater than 25. Now, Criterion 1 is an MPAP strictly greater than 20 millimeters of mercury. Criterion 2 is a pulmonary vascular resistance, or PVR, greater than 2 Wood units. That's down from the old threshold of 3. And Criterion 3 remains a pulmonary arterial wedge pressure, or PAWP, of 15 millimeters of mercury or less. We still need this to ensure we are definitively looking at pre-capillary pulmonary hypertension and not simply left heart failure pushing pressures backwards. So you might be wondering, why did the international community make this change? Well, robust data show that in the context of portal hypertension, a PVR between 2 and 3 Wood units is absolutely not normal. It's not a gray area. It represents early but definitive pulmonary vascular disease. Catching these patients in this specific 2 to 3 Wood unit window is an absolute game changer. It allows us to initiate PAH-targeted intervention far earlier, which drastically improves their chances of safely making it to and surviving liver transplantation.
Now, contrasting PoPH with its confusing counterpart, hepatopulmonary syndrome or HPS, is absolutely crucial. They are entirely different beasts, but they love to complicate our lives. PoPH, as we just discussed, is fundamentally a disease of vascular remodeling and obstruction. It's driven by smooth muscle proliferation in the pulmonary arteries. It results in an elevated PVR and significant right heart strain. HPS, on the other hand, is a disease of intrapulmonary vascular dilatations or IPVDs. In HPS, the capillaries abnormally dilate, which leads to massive right-to-left shunting, profound hypoxemia, and paradoxically, a normal or even low PVR. The real clinical conundrum for us as specialists is that these two distinct entities can actually coexist in the exact same patient. Recent pathophysiological updates highlight that both conditions actually share disrupted BMP9 signaling pathways. So if you are managing a patient with confirmed PoPH who is disproportionately hypoxemia despite your targeted therapies, you absolutely must consider coexisting HPS. This dual diagnosis is a nightmare for perioperative management, quite frankly, because they are suffering from both restrictive right heart flow and severe ventilation perfusion mismatching.
Section 2. Screening and hemodynamic diagnosis.
How do we accurately detect these revised parameters in our day-to-day practice, especially when we consider the incredibly unique physiological state of end-stage liver disease? Well, the fundamental rule is this. Transthoracic echocardiography is mandatory for all liver transplant candidates, no exceptions. You simply cannot rely on clinical symptoms to catch this. But you really need to pay close attention to the new screening thresholds. Historically, the ASLD and ILTS recommended moving to a right heart cath only if the right ventricular systolic pressure, the RVSP, was strictly greater than 50 millimeters of mercury. Now, while an RVSP over 50 gives you fantastic diagnostic specificity, it completely misses early disease. The contemporary recommendation is to be far, far more vigilant. If the RVSP is between 38 and 50, and you see any secondary signs of right ventricular strain on that echo, things like RV hypertrophy, a right atrial dilation over 18 square centimeters, or a flattened interventricular septum, you should strongly consider referring them for right heart cath straight away. The sensitivity for early detection absolutely leaps up when we use this tighter 38 to 40 millimeter of mercury threshold. Furthermore, if the TTE shows any degree of RV dysfunction without a formal assessment, the odds of that patient dying within 6 months of transplant jump 24-fold. That is a staggering statistic. Do not ignore the right ventricle on a cirrhotic patient's echo. For the multidisciplinary team, following a stepwise diagnostic algorithm is highly practical and keeps everyone on the same page. It starts with the baseline TTE we just talked about. If the RVSP is elevated or there is unexplained RV dysfunction, we proceed straight to right heart catheterization. Then, at the RHC stage, if the MPAP is strictly greater than 20, we then scrutinize the PVR and the wedge pressure. If the PVR is greater than 2 Wood units and the wedge pressure is 15 or less, congratulations, or rather, unfortunately for the patient, you have formally diagnosed portopulmonary hypertension. Of course, provided you've already ruled out chronic thromboembolic disease or intrinsic lung pathology. But what if the initial echo is completely normal? Well, we don't just forget about it. Because waitlist times can stretch into years and POP can develop incredibly insidiously, it is highly reasonable and strictly recommended to repeat the screening echocardiogram annually for all active transplant candidates. You have to stay on top of it.
Now, we must address one of the most critical pitfalls for anyone interpreting CAF data in a liver unit. End-stage liver disease creates a completely bizarre hemodynamic environment that can so easily trick even an experienced physician. First, let's talk about cardiac output. Cirrhotic patients are typically in a massively hyperdynamic state due to profound splanchnic vasodilation. Their baseline resting cardiac output might be 8, 9, or even 10 liters per minute. Therefore, if you do a right heart cath and the cardiac output comes back at 5 liters per minute, which yes is mathematically normal for a healthy person, that is actually abnormally low for an ESLD patient. It may represent an exhausted right ventricle that is finally failing against a rising PVR. You must never dismiss an elevated PVR just because the cardiac output looks quote-unquote normal. Second, let's talk about the volume overload pitfall.
If the patient is overloaded, which is incredibly common given their ascites and renal dysfunction, their wedge pressure might be artificially pushed above 15. Does that mean it's purely left heart disease and definitely not PoPH? Not necessarily. In this specific scenario, you must calculate the transpulmonary pressure gradient, the TPG. If the PAWP is elevated, but the TPG is strictly greater than 12 millimeters of mercury, this indicates a true precapillary resistance issue perfectly superimposed on top of volume overload. What do? You aggressively diurese the patient and repeat the measurements to uncover the true underlying PoPH.
Section 3. PAH-targeted medical therapy.
Having firmly established the diagnosis, we are no longer just observing these patients. We are actively bridging them to transplant using aggressive pharmacology. Let's outline this pharmacological arsenal. The primary overriding goal here is to remodel the pulmonary vasculature and drive that MPAP and PVR down to a safe threshold so we can actually get them to surgery. The 2022 ESC/ERS guidelines in the recent updates suggest an approach that is heavily tailored to the fragility of the cirrhotic liver. We generally start with initial monotherapy, heavily preferring phosphodiesterase 5 inhibitors or endothelin receptor antagonists. But here is a major, absolute clinical pearl that you must take away. Calcium channel blockers are strictly contraindicated. Now, while they might be used in some forms of idiopathic PAH for specific vasoreactive patients, in PoPH, they are a disaster. They violently exacerbate splanchnic vasodilation, they severely worsen portal hypertension, and they can rapidly precipitate fatal variceal bleeding. Never, ever use them in this population. Also, keep in mind that liver impairment dramatically affects drug metabolism. Hepatic dosing adjustments are mandatory, particularly with the ERAs, which carry a known risk of hepatotoxicity. You have to monitor their LFTs like a hawk.
As you'd expect, our treatment strategy escalates entirely based on hemodynamic severity. For mild to moderate PoPH, which we define here as an MPAP below 45 millimeters of mercury with relatively preserved right ventricular function on echo, we initiate upfront monotherapy. We then monitor them incredibly closely, assessing for that vital drop in PVR and a sustained improvement in right ventricular function. However, if the patient presents with severe PoPH, meaning an MPAP of 45 or greater, or if they are highly symptomatic with things like syncope, frank right heart failure, or severe dyspnea at rest, monotherapy is completely insufficient. These high-risk patients require upfront sequential combination therapy. In these critical cases, we will very often deploy parenteral prostacyclins to rapidly offload the right ventricle. The goal here is absolutely urgent hemodynamic optimization, because we know that they are currently at an unacceptably high risk for perioperative mortality if they were to somehow undergo transplantation today.
Section 4. Candidacy and risk stratification. Having initiated these targeted medical therapies, we seamlessly arrive at the ultimate multidisciplinary decision point. For the surgeons, the hepatologists, and you all in anesthesia, who is actually safe to list for a new liver? We must ruthlessly contrast the acceptable candidate against the absolutely contraindicated profile. An acceptable liver transplant candidate is someone who may well have started with severe POFAF, but crucially, following our targeted therapy, their MPAP has been successfully driven down to that 35 to 45 range. Their PVR is ideally falling towards or below 3 Wood units, and most importantly, their right ventricular function on echocardiography is robust. We know from extensive long-term data that these patients can tolerate the extreme hemodynamic swings of the transplant surgery. Conversely, the contraindicated profile is crystal clear. If, despite maximal medical therapy, the MPAP remains stubbornly greater than 45 millimeters of mercury, or if there is severe right ventricular dysfunction, liver transplantation is strictly contraindicated. There is no gray area here. The perioperative mortality in this specific group approaches 70 to 100%. Putting them on the operating table is quite literally inviting a catastrophic intraoperative cardiac arrest upon reperfusion. In these cases, we must defer listing, escalate their medical therapy if possible, or, sadly, consider alternative palliative pathways.
Because waitlist mortality for untreated POP is exceptionally high, the transplant community developed MELD exceptions to expedite these patients. Historically, getting one of these exceptions was somewhat subjective and highly variable between centers. Now, the criteria are far more rigid, standardized, and heavily evidence-based. To qualify for a MELD exception today, a patient must be formally diagnosed via right heart cath and then undergo a mandatory 6 to 12 weeks of targeted PAH therapy. You simply cannot just diagnose them and list them with exception points the very next day. You must prove biological responsiveness. After those 6 to 12 weeks, a repeat right heart cath must actively demonstrate improved hemodynamics. Specifically, the MPAP must drop below 35 or the PVR must significantly improve. If they prove that they can be medically optimized, they are granted the exception points to get them into theater before their failing liver takes their life.
Section 5. perioperative, and post-LT management. We now enter the absolute crucible of the operating theater. This speaks directly to the intraoperative and immediate post-operative challenges that the anesthesiologist and the intensivist will face. Liver transplantation is a massive hemodynamic roller coaster on a good day, and the POTH patient is already riding right on the edge of the cliff. Let's look at the prehepatic phase. The primary vulnerability here is precipitous, sudden hypotension. Think about it. You have a patient who is already massively vasodilated from their cirrhosis. As the surgeons make the incision and begin dissecting out their native liver, you inevitably encounter significant bleeding. Furthermore, as soon as the abdomen is open, there's often massive, rapid drainage of liters of acidic fluid. This results in an immediate, profound decrease in right ventricular preload. A right ventricle that is already struggling to push against high pulmonary vascular resistance suddenly has absolutely no volume to pump. This leads straight to a catastrophic drop in cardiac output and severe systemic hypotension. Judicious volume resuscitation and incredibly targeted vasopressor use are absolutely vital right here to maintain coronary perfusion to that highly strained right ventricle.
But the true ultimate test of your anesthesia skills comes during the neohepatic or reperfusion phase. When the portal vein is finally unclamped, the physiological insult to the body is staggering. This is the dreaded post-reperfusion syndrome. The patient is suddenly hit with multifactorial hypertension. But it's far more dangerous for the PoPH patient. Cold, acidotic blood, rich in potassium and vasoactive cytokines, washes completely out of the donor graft and directly hits the systemic circulation. This simultaneously depresses right ventricular contractility while causing a sudden massive surge in right ventricular preload. Think of the mechanics. You have a weak, chemically stunned right ventricle suddenly asked to pump a massive volume load against an already exceptionally high pulmonary vascular resistance. This specific physiological mismatch can rapidly, in seconds, precipitate acute right heart failure and cardiac arrest on the table. And remember, volume overload secondary to your management of the patient's coagulopathy earlier in the case only compounds this specific RV overload risk.
Because the margins for error are virtually non-existent, advanced intraoperative monitoring is not optional. It is strictly mandatory. You absolutely must have transoptical echocardiography, or TEE, actively running and being interpreted in real time by someone highly experienced. TEE allows you to visualize RV volume and contractility beat by beat. It lets you instantly distinguish between hypovolemia and genuine RV failure, which guides your fluid and ininterrupt strategy precisely when seconds count. You must have defibrillation capability immediately ready. And crucially, modern guidelines heavily advocate for setting early triggers for veno-arterial ECMO. If you see unrelenting right ventricular decompensation on the TEE upon reperfusion, you do not wait for the arrest to happen. You must have the ability and the institutional protocol in place to rapidly crash onto VA ECMO to bypass those failing lungs, offload the right heart, and salvage the patient. Proactive, not reactive. If you successfully navigate the surgery, the post-transplant phase in the ICU requires immense discipline. The strict, unbending post-operative rule is this: do not wean PAH-targeted therapy in the immediate, vulnerable post-transplant period. The pulmonary hemodynamics can actually acutely worsen in the first few weeks post-op as the hyperdynamic state slowly resolves and massive fluid shifts occur throughout the body. The strict protocol is to maintain their preoperative PAH therapy unchanged upon their transfer to the ICU. You then mandate a formal follow-up TTE at 3 months post-transplant. Only at the 3 to 6 month mark, if clinical and echocardiographic improvement is firmly verified, can you even consider cautiously weaning the therapies. Premature weaning is a major cause of late right heart failure and tragic graft loss. Don't rush it.
Section 6, 2026 ILTS Guideline Updates.
Let's bring this entire explainer to its conclusion by synthesizing the absolute most critical takeaways from the latest guidelines. Synthesizing the 22 new recommendations gives us these non-negotiable clinical takeaways. First and foremost, adopt the revised hemodynamic definitions. We are now strictly looking at an MPAP over 20 and a PVR over 2. We must catch these patients earlier in their disease course. Second, TTE screening is absolutely mandatory for all candidates, and we are using a lower threshold, an RVSP of 38 to 40, or any signs of RV dysfunction to trigger that diagnostic RHC. Third, do not rush them to surgery. Medical optimization with PAH therapy for 6 to 12 weeks is required, and an MPAP stubbornly over 45 is a strict, hard contraindication to transplantation. And finally, perhaps the most genuinely encouraging takeaway for us all, the combination of targeted PAH therapy and liver transplantation, when done correctly and safely, yields excellent long-term survival that is now totally comparable to transplant recipients who never had pulmonary hypertension. It is a curable disease in the right hands. So I leave you with a challenge for your own clinical practice and your academic research. What is the next frontier in POFAP management? We urgently need to unravel the precise, molecular, pathophysiological link between hepatopulmonary syndrome and portopulmonary hypertension. Why exactly do some patients develop both, and how on earth do we best manage that devastating physiological combination? Furthermore, what is the optimal timing and the evolving role of mechanical circulatory support, like prophylactic intraoperative ECMO, in those truly borderline candidates? The 2026 guidelines have brought us this far, but the future of transplant anesthesia completely relies on us answering these exact questions. Thank you for your incredible attention today, your absolute dedication to your patients, and I genuinely hope these clinical insights serve you incredibly well during your next complex case in theater. Take care.